He's the chair of the Department of Psychiatry and Psychotherapy at the University of Munich. And I think his talk will follow quite well from some of the concepts that we've just heard about within the realm of mental health and cognitive aging. So please join me in welcoming Professor Peter Falkai.
Yes, thank you very much. As you can see, I have, after listening to the first talks, I have slightly changed sort of the topic, because I think things we have done which are nicer fitting to the whole topic, but I still will keep with depression. So you will see certain sort of aspects of depression there. So the question of, if you look at mental disorders like depression or schizophrenia, the question is there any need in changing treatment? I mean, that was the original sort of hypothesis. I said, okay, I'd like to convince you that to detect depression is not that difficult. And for the majority of the cases, it's an illness which is good, well treatable. But we have a problem here, and the problem is depicted here. If you actually look at the sort of upper part, you can see quite nicely that if you look at severe disorders like depression or schizophrenia or bipolar disorder, these people have episodes, you see, and between these episodes, they are fine. So they have no symptoms. They go to work, they have partners, everything is in shape. The problem starts in the second half of the course. As you can see, you have episodes, and in between the episodes, actually there are residual symptoms and they don't go away. And that's the problem. And that makes these disorders very difficult, because if we go down and actually look for what we call recovery in the sense of really being able to do an independent life, you see, you end up in 15% in people with schizophrenia, 45% in people with depression, but it's not 80 or 90 or 100%. And the problem of that is actually that these sort of residual symptoms constitute of two aspects. That's the negative symptoms, and the secondly is the so-called cognitive dysfunction. So as a matter of fact, we actually have in half of the patients have a problem here with cognition. And just to give you an example what it means, one of my patients I'm accompanying for 20 years with schizophrenia, he studied law. And when he studied law, becoming psychotic, so developed the illness. And now he is actually working in a restaurant as a cooker helper. So he helps in the kitchen. And he's not able to read a book. And I mean, if you recall Kraepelin, who said, you know, dementia precox, so in a subgroup of the patient, we really have severe cognitive impairment. And that's why 15 years ago, we thought we concentrate on this issue. And as you can see, the question is, how can we actually deal with that? How can we treat that? And as a matter of fact, there is no medication at all at the moment, nothing. No psychotherapy, no tablet, which actually improves cognition. But it seemed to be that if we look at aerobic exercise, and for instance, we look at depression, there seemed to be quite a significant effect you can actually get. And if you go into sort of the studies in more detail, you can see quite nicely that actually you can look for very different variables like illness, study quality, exercise type, and so forth. And you find a pattern where obviously exercise does something good. So, and this is true if you go to schizophrenia, an illness which is even more severe. I've just given you an example of that patient, of that low patient. And overall, you find that there is an effect which is not low. I mean, we're speaking about an effect which is comparable to the effect we have with medication or psychotherapy. And if we go into more detail, actually, you can see quite nicely that there are certain domains in cognition which do seem to profit from cognitive, let's say, cognitive exercise or aerobic exercise. So it was actually a paper, and she was quoted before Henrietta Prague. When I actually read the paper there, and you know, it was this thing about ruminating, about cognition and things like that, I found capacity to regulate neurogenesis of the hippocampus, equally synaptic plasticity and learning. So that seemed to induce that. And I just stumbled over that and said, oh, interesting, there's something, learning is improved. So that was the beginning when we actually designed what I would call translational study. And the idea was to have patients with multi-episode schizophrenia and ask them to do indoor cycling 3 times a week for 30 minutes. And we've done that, and our first control group were actually patients with schizophrenia, again doing table soccer, as a control condition 3 times a week, 30 minutes. And then we had a second control group. These were healthy people who actually had to cycle 3 times a week for 30 minutes. And the hypothesis was that training your brain, which actually improve not only functioning, so improve sort of cognition, but in addition, because there is a quite clear-cut evidence that patients with multi-episode schizophrenia have hippocampal volume reduction by 5 to 10%. This is well replicated. You have huge amount of imaging studies. So the hypothesis was that with this easy sort of intervention over 3 months, keeping medication the same, keeping psychotherapy the same, would increase the volume of the hippocampus. And in our initial study, what we found, so that was the control condition, so these were the healthy people, and you can see, so entering the study, and after 3 months, they have a volume increase. But interestingly, those patients with schizophrenia who didn't do exercise, who did actually the table soccer, didn't show a hippocampal volume increase, but actually those guys who actually did the indoor cycling showed a volume increase of the hippocampus, an improvement of cognition and reduction of negative symptoms. So that was quite neat. I mean, it's often that you have these, nice hypotheses from animal studies, you translate them into humans and nothing works. Well, at least that seemed to work. And then I have to say that it was to talk by Gerd Kemperman showing this slide when he actually alluded to and said, look, I mean, if you add enriched environment, you can actually improve neurogenesis. And so I started to think with my group, how can we do this in humans? Well, what is enriched environment? And we had different ideas. I mean, some guys said you should go for football. Others said you should make dancing and other things. And it was actually when my patients told me, why don't we do cognitive remediation? Because you asked us to do that anyway. And so that's standardized, and we do that. So what we did was a follow-up study. And actually, again, we had multi-episode patients with schizophrenia. We asked them again to do the indoor cycling. And then after 6 weeks, we added cognitive remediation, twice a week for 30 minutes. We had the healthy controls, poor guys. So not only they had to cycle, but after 6 weeks, they had to do cognitive remediation. And then again, in the third group, we had the table soccer patients, and actually they had to do the cognitive remediation. And the hypothesis was based on the animal studies that the combination of both, so the sort of exercise plus cognitive remediation, would actually do a functional improvement and not only cognitive remediation. And that is what came out. So you had the endurance training and cognitive remediation. This is entering the study, looking for global functioning. So most people won't know that the GAF score for people like you and me without a coffee in the morning, we have like 90. But if you have schizophrenia and you're admitted to the hospital, you have 30. And if psychiatrists have done a okay job, you are at 50 when you go. So, so we had an average patient sort of stabilized, so they entered. And then after 6 weeks and after sort of 3 months, and you can see they gained 10 GAF points, which is 20%, which is just keeping medication stable and psychotherapy stable. It's quite nice, It's a whole category of improvement. And down you see table soccer and cognitive remediation, no change. And if you look at social adjustment, things you ask people, what about household, social leisure activities and so forth, and they improved, but didn't improve if they had table soccer. And it was interesting that certainly because they received cognitive remediation, some cognition improved. So indeed, based on the animal studies, we were able actually to translate that. And in exercise 3, we will actually try to define the dosage we need in order to use exercise as a drug, in order to improve cognition in, let's say, half of the patients. Because there is one problem, that if you actually look at the distribution of the patients, only about half will benefit. And some patients will hate it. They say, oh, this is just a pain in the neck, and I'm getting even worse. 2 of them, I even got psychotic. And the question is, what is this? Why do some people benefit from exercise and why don't? And we have looked in a more detailed way at the hippocampal volume. As you can see, I mean, we found this volume increase, and it was interesting. If you looked functionally at the responders, so those ones who seem to benefit significantly, even more than the 10 points, you can see that their hippocampus, even in the subregions, increased in volume. And those guys who didn't show functional improvement actually didn't benefit, but their hippocampus rather even sort of became smaller. So it seemed to be a different pattern, not only of your behavior and functioning, but that relates to, I think, certain, let's say, structures underlying. So our next question was, okay, what about the pathophysiology? Can we understand anything along it? So what we did, and our geneticist always says brave, and I say, well, sometimes you need to be, we have done GWAS on all these people. And the hypothesis was that let's see whether we can actually relate volume change to any of the genetic pathways. So what we did, we have actually looked, and what was interesting to see, that there was a significant correlation, especially for CA4 dentate of the hippocampus, that if you had a smaller polygenetic risk score, so a lower degree of risk genes for schizophrenia, you had a higher degree of volume change. So the more pathological genes you have, the lesser is your ability actually to show volume change and functional improvement. And the question is, but this is certainly, I think, only based on hypothesis. The question is, can we look into the pathways and see what is coming out? And this was quite interesting, and that relates quite nicely to what you said, Gerd. It was actually neurodevelopment and synaptic plasticity which were at the center of that. Well, we are following up of that in a large run and hope to see into that. But I think it is a way how we can really translate a mechanism, I think, down, hopefully, to mechanisms. And this is just an outlook, last 2 minutes, and then I'm done. You know, I think that what we need actually not only translate, but we need to combine animal studies plus studies in humans. And what we did actually, again, in a large study, we'd like to follow up functional outcome, hippocampal plasticity, and synaptic pathways, targeting synaptic pathways. And for that, we use in parallel the TCF4 transgenic mice, which in a way models some features of psychosis. And we can speak about this in the sort of discussion if you want to. And we do the same thing. So these guys run, and we look with PET and we look with MRI to see whether what we see in the model we can see in the sort of real, sort of human in base. And the idea is, again, to do a follow-up, and you can see this is quite a large sample. This is transdiagnostic, looking at schizophrenia, bipolar disorder, and depression. And we actually type these people based on their outcome. And the hypothesis is, as we go along and exercise our brains, we improve the amount of people with a good outcome with the intervention. And so the idea would be, again, then look for the synaptic pathways using PET. So that would be, I mean, we have started to do that in the mice, and we can quite nicely see a distribution of the so-called SV2A ligand, and we'd like to do that in the mice, so we will have relaxing mice and the sort of exercising mice, and the hypothesis would be, and that's the same in the humans, that improves cognition and that doesn't change cognition at all. So overall, I think this is where leading to, you see, I've left only a bit of depression, but I thought that might be more interesting. There is increasing evidence that schizophrenia and other severe mental disorders, and I think that includes depression, have a disturbed regenerative capacity of the human brain, underlying disturbed functional outcome. Aerobic exercise improves symptoms, cognition, and functional outcome in these disorders, and this is accompanied by brain volume changes in about half of the patients, And the question is, what is actually determining that? With that, I'd like just to introduce you to the people who really do the work. So it's actually the guys who do the clinical work. That's Andrea, and that's Isabel, who does the imaging work, he does the genetic work, the mouse work, and helps us with the coordination. With that, thank you very much, and I'm happy to receive questions, if there are any.
Thank you very much, and it's especially exciting, I think, to see outlines of a study that links the animal and the human within the field of exercise research. Are there any questions?
People need a break.
Yes.
Over there?
No, I really like this work a lot, and I just wonder about your intuitions as to the best or minimum necessary dosage of the exercise component of this cascade, because probably, I mean, I'm sure what you have in mind, that it's the exercise that is basically creating the neurons, and it's the cognitive work that tells them what to do. I mean, I'm simplifying. And then, so you want to kind of push the system out of its present equilibrium, and then I always ask myself, how do we know whether it should be 2 weeks, 2 months? So what's the dosage of the exercise component?
Well, what we based on our own data, I mean, I always distinguish between exercise as a drug and exercise as a maintenance therapy. Because you see, I think what we have done, we have stopped after 3 months and did a follow-up after 3 months, and most of the effects are gone, like in normal, healthy people. But your question is, what about the dosage we need in order, in a patient with cognition, to get that out of the dyscognition? And that seems to be 3 times a week, 50 minutes. And we do exercise 3 in order to nail that down. Now we have 154 patients out of 180. So by March next year, we should have the study, and then I give you the exact. But we did 35, 40 minutes, and 50 minutes just to have a quite nice steep, and you really define, you know, this is the dosage you need, you have the best effect. And we have just started the design of a maintenance study where, based on the WHO, we have said, okay, why not every day 15 minutes, adding up to 75 minutes per week in people who have dyscognition, but you know, what we want to prevent is a decrease in their physical and mental health. And that would be the other way. That would be a different dosage, but with a different aim.
Thank you for that very interesting talk. When you were mentioning the exercise program and some of your patients with schizophrenia loved it, some really didn't, and 2 became psychotic, I was wondering whether there was a relationship between those who enjoyed it or didn't, and whether they benefited.
The distinction between sort of, to say the first thing, it is interesting if you actually include patients into this exercise study. We had the highest dropout rate, which was low, 10, 15% in the first 2 weeks. Once they stayed in the study, they stayed until the end. And even, you know, we had a full attainment after a year, which was fantastic. So they liked it. But within those people, we had people who really felt that they had some benefit from that. That was the difference. But they stayed in the study, but they said, you know, I feel better. And we in between asked them, do you think you'd like to stay on after we stop? And that was the distinction. There were guys who said, I think I can think about continuing, and those was the girls who actually felt that I have some improvement. So what we fiddle around at the moment with the larger N, I think this is the hypothesis, there is a genetic framework which actually allows you, based on exercise, to exercise your brain. And if you don't have that, very simply, then you shouldn't exercise because it won't help your brain.
Yeah, thanks for great data and talk. And that was actually something I wanted to ask you. We discussed it a little bit already before. So in the beginning, you said something about maybe being able to individualize treatment for patients based on something, for example, genetics. So are you actually planning a study where you would look more specifically, for example, if someone who is not so prone to respond to exercise, if they maybe respond to more exercise or to different exercise, Or would you tell them to do something different altogether? What
Yeah.
could that be then?
We've discussed that. I think, our hypothesis is about 40 to 50% benefit, 40% don't, they get worse, and about 10, 20% they, nothing happens. And what we try at the moment, based on our genetic data, disentangle different mechanisms, and we spoke about inflammation. So my whole hypothesis is that we have this synaptic subgroup, so they show hippocampal change over time, and we have the non-synaptic, and I think these are the ones possibly where more inflammatory mechanisms are involved. And for the next study, what we did, very simple, you shouldn't tell people, just look at CRP. So, C-reactive protein, and see whether then they were above 2 and sort of in the normal range, whether that differentiated from the beginning. So these are data we will analyze by March. Hopefully we will be a bit more sophisticated, but at the moment I'm thinking that what we will do, because we have a scan on these people, we have immune parameters, and hopefully in addition synaptic parameters, and then hopefully that within the first months distinguish and see who needs after 3 months more and who doesn't.
I was just wondering why you chose two very different things to do. Riding a bicycle might be a very lonely job, and playing table soccer is obviously social.
We made sure that they had to do that, the social factor. So being a psychiatrist, social is always around us. So we had always groups of 4 people. So 4 people were riding the cycle, and 4 people doing the table soccer. The idea from the table soccer came from the patient again. Because we have asked them, what do you like to do most? And they said, well, if we don't have therapy, we go out and do table soccer, have a smoke, and have a coffee. And I said, okay, this is our control condition. Because, some people say, well, moving that way possibly might move your brain too. We've looked at that with sophisticated brain imaging, and indeed, table soccer does change your brain, but at different portions. So exercise more the temporal lobe, and table soccer more cingulate and motoric regions. So it does change the brain, but I think my view would be that you need to actually activate larger muscle groups. Whatever happens, I mean, Henrietta from Prague has some interesting ideas that some stuff comes out of the muscles and so forth, in order to actually do something to the brain. There is only one study where they compared yoga and cycling, and indeed yoga was as efficient as exercise, but no other exercises. So you need cycling or yoga in order to have this effect.
Okay, thank you.
I think we missed that comment, which was we need to cycle to yoga classes. So I think we'll end there. Thank you very much to all the speakers in the session. And thank you also to the audience for all your questions. So we now have a lunch break, and please try and come back here by 1:40.